Hello, thank you for joining us. We'll get started in just a few minutes. Greetings. We're grateful that you're here with us. Please share in the chat feature where you're joining from. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. The nurse planners and content experts disclose no relevant financial relationships with ineligible companies. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we'll have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We'd like to thank our speakers for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenters and do not necessarily reflect that of Sigma. Our speakers today are Julie Waldrop and Jane Dunlap. Julie has been a nurse since 1985 and a practitioner since 1991. She is also a teacher and scholar, teaching and nursing since 1994. She loves helping a student or practicing NP enter the scholarly realm by presenting at a conference or publishing a paper. Julie is also a fellow in the American Association of Nurse Practitioners and the American Academy of Nursing and serves as editor-in-chief of the Journal for Nurse Practitioners. Jane is a practicing family nurse practitioner at Baylor Scott & White Health and Associate Clinical Professor at Texas Women's University in Houston, Texas. She recently completed a DMP postdoctoral fellowship in evidence-based practice. Her scholarship interests surround timely treatment, provision of special populations, strategies to reduce evidence to practice gaps, and nursing faculty scholarship standards. We are so grateful to have both of you. Welcome.
Thank you so much. And we are super excited to be here and so excited to see all of you joining today and where you're from. I'm joining you from North Carolina, and my colleague Jane is joining you from Texas in the United States. We have 3 learning outcomes today. We hope that by the end of our time together, you will be able to describe how the mountain model differs from other evidence-based practice and quality improvement frameworks, and that you will be able to generate a rationale statement for the need to disseminate evidence-based practice quality improvement initiatives so that we can shorten the research to practice gap. And lastly, we hope you'll start to develop in your mind examples of how you might be able to apply the mountain model in your current role as a nurse, whatever that and wherever that might be. So we're going to start with a poll where we'd like you to tell us about your current role and nursing experience. And we give you just a few minutes to do this because there's a lot of you out there. And then we'll all see the results together. Thank you. All right. We have a wonderfully qualified group of participants on our webinar today with advanced degrees, and many working in acute care settings. That's great. Thank you. That helps us know a little bit about who we're talking to today. And now one more question. If you can tell us your experience with evidence searching questions. So questions that help you find the evidence that you need to support what you want to do in your practice. Okay, so many of you are familiar, some of you less so than others, and some feel pretty good about your ability to use evidence searching questions. Thank you. All right, so even if you feel pretty good about your ability to use the current evidence searching questions that are out there, in particular, we're going to just call out the PPCO evidence searching question here. We also would count ourselves as very familiar with this question, having, as our introducer said, been around nursing education and practice for quite a few years. But have to admit that we're feeling just increased frustration with the PPCO and all the iterations that are out there to guide our evidence searching process. And we also had another problem that we were struggling with. And we kind of came upon these problems because we decided to write a textbook together for pre-licensure students on these topics, and struggling to explain things as clearly as possible to future students, we ended up trying to figure things out better for ourselves. And so we were having trouble with explaining what we saw as a seamless process that moved from research to evidence-based practice to QI. Next slide, please. So we'll start with the first problem, the search for evidence to help us find solutions to our problems in healthcare. So as you would hope to, we all would do when we identify a problem, is we go to the literature and see what kind of evidence there is out there to help us learn more about the problem we're experiencing. And what we found with the PPCO question, or any question to search for evidence in nursing, that there was very limited evidence to support its use specifically in nursing. And for our second problem, we found that there were no models that truly incorporated everything we felt needed to be incorporated in a model to start from research to evidence-based practice to quality improvement. So we saw this as an opportunity to develop a new evidence-searching question for nursing and healthcare partners if desired, and to develop an EBPQI model for nurses at all levels. Next slide. So just to give you some background in what we found when we started looking into PPCOs or PPCO-Ts or PPCO-TSs, is that, in fact, it was developed for research in the field of medicine. And it is a really good question for comparing therapies, drugs, procedures, tests, etc. And the usual comparison is to usual care or a placebo. Unfortunately, it very much privileges experimental research and medical interventions, and matches with our traditional evidence hierarchy, where systematic reviews and randomized controlled trials are at the highest level of quality of studies. Unfortunately, historically, this type of research has not included women, minorities, and other historically marginalized populations in research. This is improving, but a lot of the studies in the past did not do this. So you have a risk there of identifying a treatment that may not have actually been studied well enough in your population of interest. And maybe the worst thing, and the thing that students struggle the most with, is that it supports premature bias toward an already known intervention. And it really begs the nurse to compare one intervention to another, as opposed to finding all the evidence on all the solutions that might be possible, including ones the nurse does not yet know about, which might be better. Next slide, please. And nurses have varied interests beyond medical treatments, right? We are involved in all aspects of providing health and healthcare. And so we're interested in management processes. We're interested in whole systems of care. We're interested in programs. We're interested in policy, protocols, and in the community, so many things, including, for example, public disaster responses. And the last issue with the PPCO is that it doesn't always address the need to understand or learn more about the problem itself first. Next question. But you say, there are other types of PPCO questions. Yes, there are. There are many. And this is a problem in and of itself, because if your problem or issue does not fit as in the traditional PPCO as a therapy comparison, for example, then you go and look for, you are tasked with having to go find which question might better fit your issue. And these are just 3 examples of the many questions that are out there. So with our model, which is an acronym is PPCO, the first P reminds you that you need to find out and understand the problem you want to address first. You cannot skip over this. In fact, as a nurse, your expertise, your ability to understand and know about the problem you want to address gives you credibility and will help you in being able to implement a practice change as a leader. And then once you understand the general problem, you need to understand the specific problem in your local context. And an example of understanding a general problem would be the problem of childhood obesity. And the specific context that you are in would be understanding the percentage of children who are obese in your practice setting or your community, for example. Next slide. So here's an example where this might not be a match or the same thing. If, let's say you're interested in obesity and you go out and look at the literature, and there is a plethora, tons of research on obesity in children out there. But I had a student who wanted to make an impact in this area. But when she got her first job as a nurse practitioner, she got it in a pediatric practice that really focused on holistic health and wellness. And she found that in that setting, very few children were actually overweight or obese. Continuing to do an EBPQI initiative to improve childhood obesity was obviously not indicated in this setting. And in fact, if efforts had been made towards this improvement, it would end up being a waste of valuable healthcare resources. So not only do you need to understand the general problem, you need to understand the local problem as well. So the first P helps you remember to do that. The second P stands for population, and this is where you can bring in your specific population that is impacted by the problem. That's usually fairly simple. You know who that is. The next big change is actually the word change. And this is meant to help you when you are looking for solutions to not be biased, to look for and identify all the possible research out there that has made an impact on your problem. And then your outcome is what's the observable difference that the change makes that you want to see. And really, this can be applied to almost all kinds of problems. So let's go through a whole example of using this evidence searching framework. We have a nurse administrator who notices that adult patients with cancer who have newly placed ileostomies frequently present in the emergency department with dehydration, thus leading to readmissions. And he thinks this must surely be a preventable problem and decides to collect some evidence using the PPCO framework. So the first thing he wants to do is better understand the problem in general and in his local context. So the problem in general here is dehydration. And we can go on to the next slide. And so he searches the literature using a simple question, such as, what is the incidence or prevalence of dehydration in adult patients with cancer and an ileostomy? And with this question, he finds that dehydration is indeed a serious issue and, in fact, the most common reason for readmission. And that in addition to that, dehydration can result in numerous consequences for these patients and be a significant resource burden on the healthcare system. So now he understands and has some evidence to support that this is, in fact, a general problem. Next slide. And that now he needs to be able to find some evidence or data from his local situation that supports what he's observed. So he decides that if he goes to the admissions office, they might be able to help him identify the most common admission diagnoses for patients with cancer in an ileostomy, and he can calculate the rate for the prior 6 months. And in fact, this calculation shows that his observations were accurate, and readmission for dehydration has been an ongoing problem for the organization. So now he's like, okay, what are the possible solutions? Now we move on to the next parts of the framework. He knows his patient population, it's adults with cancer and an ileostomy, and he wants to find out what has been recommended or done to address the problem. So changes in practice, processes, etc. And how these outcomes are measured. In his case, he cares about readmission. So his search through the research reveals that short-term follow-up evaluation for signs and symptoms of dehydration after ileostomy placement, and at that follow-up, additional patient education on self-management has been shown to be the best way to prevent readmission. So this research he has found demonstrates this. So he develops a proposal that patients be given a follow-up appointment to be seen by a nurse practitioner 4 to 7 days after their ileostomy placement so that they can be assessed for dehydration and receive additional education. And now the nurse is ready to present to upper administrators his evidence on the problem and his recommendations for a solution. And not surprisingly, they're eager to hear this because he has research-based evidence as well as internal evidence to support his potential practice change and quality improvement. So in summary, evidence-based practice quality improvement initiatives begin with a complete understanding of the problem. And we can't really emphasize this enough because it's something that we have seen overlooked time and time again, and really hinders progress when nurses want to lead practice change. So the PPCO question can serve as like a practical and accessible starting point for an EBPQI initiative. And as nurses, we are involved in so many spaces in our communities, clinical spaces, academic spaces, and we want to affect positive changes in our health systems and the lives of our patients. But in order to do so, we also might need to change the way we do things. So I'm going to turn it over to my colleague, Jane, to talk about our next problem that we addressed.
So this is what Julie and I saw as the bigger issue, is fully integrating evidence-based practice with QI. And so the paradigms of EBP and QI have evolved exponentially over the past 30 years, and increasingly so in the last 5 years, with more and more calls for congruence, because as Julie articulated, evidence-based practice is that external evidence that we need to rely on, and quality improvement has the sustainability piece that's missing from evidence-based practice oftentimes, and so the two therefore can't be uncoupled. So given the growing complexity of healthcare and related fields, fully incorporating them is urgently needed. Research studies are constantly producing new evidence for us that can inform practice. However, the term evidence-based alone, just evidence-based without the practice, describes using evidence in any way, and so it can fail to capture the central tenets of evidence-based practice. And from the poll, we know we have a very experienced audience overall today, many of you with a doctoral degree, but for anyone that doesn't have these 3 purple strips embedded in their brain, it's really worth the space, because to have evidence-based practice, we have to have the best available research evidence that we use that's synthesized, graded, appraised, and synthesized, combined with clinical expertise and patient and family preferences. And that's that trifecta that we get. So we have to have those three things. QI is a term that was originally developed for use in industry. And so evidence used in QI is specific to a local organizational context or within the borders of a specific place. But as you know, with nursing, we're not in a factory perfecting a knob. We're doing practice. It's a practice-based profession. So for a search for the evidence, so as Julie said, we were engaged in another project, and so we were trying to find a fully merged framework to use. And so we did a search of the literature initially and then continuously, trying to find a framework that merged the two. And in doing so, we found two, Levin et al., and that's from 2010, that combined the 7 steps of evidence-based practice, the process of it, with the QI approach of the PDSA cycle from the model of improvement. And it used the term evidence-based practice improvement, or EBPI. It also said performance improvement in there, but there were not the clinical preferences, clinical expertise, and patient and family preferences included specifically in that model. Then more recently, Helm et al. Integrated the steps of EBP with the lean process improvement method. But again, we couldn't find any models that fully encapsulated both evidence-based practice and QI principles. And that's what led us to develop the Mountain model. So just briefly here, as we know, research, EBP, and QI are distinctly different, but yet they're interrelated, and we need all three across the evidence continuum. So research, that's the generation of new knowledge, and it uses scientific methods, and it's generalizable, which we'll talk a little bit about more at the end. Then sandwiched here in the middle of this slide, you see evidence-based practice, and that's the use of the best available evidence from research combined with clinical expertise and patient and family preferences, and it relies on research. That's the bedrock of it. QI, that's improving processes, and that uses improvement methods such as the PDSA cycles from the model for improvement, Lean, Six Sigma, etc., and it can have transferability. The goal of all of these is high patient care. And so we need them all to work synergistically together. And so just one final poll for anybody that's able to participate. We want to know about your experience with EBP and/or QI models. And so if you could take a moment to tell us about that, we would greatly appreciate it. Okay, excellent. So we see a curve here where we have some folks that don't have experience. The majority of you report moderate experience, a little over half, and we also have some experts in the group. So great to know. Thank you so much for your participation. And so now we want to introduce to you the Mountain model, and it's the Mountain model for EBPQI initiatives. And so we use the term EBPQI here because, as we discussed, nursing is a practice profession, and the P for practice really symbolizes that actual change that takes place, truly the hardest part of the entire process, because we can have all the high quality research and all the internal evidence, but if we can't engender a change in practice that includes behaviors, processes, structures, then there won't be improved quality, period. So we really can't hone in on that enough, that we need, if we can't cause that change in practice, we won't achieve improved quality. So we have to have that practice change. So the Mountain model, we developed it as we were engaged, as we said earlier, in something else for pre-licensure nursing students, and looking at those paradigms specifically of research, EBP, and QI, and wanted to explain what we saw as that ideal interrelated process. So iterative versions of this Mountain model were shared with experts in EBP, QI, implementation science, and research along the way, and their feedback led to helpful revisions and subsequent expert validation of this model. So as you see, the first level above the base of the mountain, which the base of the mountain is research, external research evidence. Right above that is EBP, and that's where we're applying the research, the clinical expertise, and patient preferences in your practice setting, and this level is compatible with the use of many EBP processes and protocols. For example, the Iowa model, the advancing research and clinical practice through close collaboration model from Dr. Melnick. If you stop at this level, however, it's hard to ascertain whether the practice change was actually effective. So to make successful and sustainable practice changes, you need to add internal evidence, which you see as the next level, to identify outcomes or measures that can provide internal data showing that the practice change has made an actual difference. Additionally, to increase sustainability and continuously improve, EVP changes must be purposefully and consistently monitored using both SMART, as you see, specific, measurable, achievable, relevant, and time-bound aims, and the QI method, so we get that sustainability piece up there near the top. So accessing these levels in an ascending fashion culminates in producing an evidence-based practice quality improvement initiative, which you see above there at that snow cap level, just above that. And the flag symbolizes that summative goal of dissemination. And that's important for all EBPQI work, to expand the impact of successful practice changes so that the improvements in learning that occurs throughout the EBPQI initiative is shared and can be adapted to other contexts and settings as appropriate. So let's go ahead and work through another example together. So perinatal care services are closing across many communities. And let's place you as the nurse described in this example. So you work in a public health department in a rural county, and you've just received word that the only hospital in your county is no longer going to provide prenatal care or labor and delivery services. In your sparsely populated but geographically large county, people are already having difficulty finding transportation to the hospital, and there's transportation barriers there that you're well aware of. So now birthing people will need to travel an additional 75 to 90 minutes to access OB care at the next closest hospital. And you're very concerned as a nurse that this hardship will keep many patients from receiving prenatal care. Because you feel strongly that all pregnant persons should have access to safe and high quality care, a feasible solution to address this problem begins with a search of external literature and research evidence using an evidence searching framework for nurses. So you're going to begin by developing a PPCO, problem, patient population change, and outcome question to guide your search for the evidence. So here we see this depicted in a table format. So what is the problem in general? And then specifically to the local context with internal evidence. And so we know that the perinatal services are going away at the county's one and only clinic. And so you want to proactively look at this. Who does this impact? This is going to impact all of the childbearing persons in your area. So change, and this is where we don't want to pick something specific, and we don't want to bias the search with terms such as increase, decrease, anything like that. We want to specifically look at alternatives for this closed OBGYN clinic for the delivery of prenatal care. So we're going to explore in the research what is out there, and the outcome, the goal would be safe perinatal care. So the question could read something like, in childbearing persons who do not have perinatal care services, what alternative care services have been used to provide that safe perinatal care? So here we are. And so after searching the evidence, you critically appraise the evidence that you have found, and you learn that some nurse-led models of care have been used successfully to provide prenatal care, especially in other countries. So one model that seems to be very successful in reducing maternal and infant mortality and morbidity is in the United Kingdom, where nurses have provided prenatal and postpartum care to patients within their homes. And this service has been seen as and perceived as extremely valuable by patients. So as you look for internal evidence that might help, so that's that next level of the mountain, right, as we move up, you find that your county, in fact, at the health department, when you're looking there, they used to provide prenatal and postpartum care services to women in their homes. But this service was discontinued years ago when the obstetrics practice opened. So although there's no past data on effectiveness, you note that the county infant and maternal death rates were lower during this time when the service was provided compared to more recent statistics. Next slide, please. So this is time for us to develop those SMART aims. So looking at the external research evidence coupled with that internal evidence that you found, you're going to develop some aims and a proposal to restart that peripartum home care service in the county as a first proactive step to the impending lack of maternity care services that's coming down the pipeline for the people near you. So what are some SMART aims? So number one, 80% of pregnant women or birthing persons will enroll in the peripartum home care service, and that's your process or fidelity measure. Number two, the county's infant mortality rate will remain the same or improve, and this is an outcome measure. And then three, patient scores of their satisfaction with the peripartum home care services will be 4 or above on a 5-point scale, and that is your balancing measure. So now that you have your SMART aims and you know your purpose, it's time to move up to the QI level. So any one of the QI frameworks, such as PDSA, Six Sigma, Lean, can be used along with implementation science to implement and evaluate this initiative. In this example, there was sufficient research evidence externally to support making a change in practice. But if your team had found insufficient evidence to warrant a change, the mountain model would then have still provided guidance. In such a case, the team would have been made aware at the EVP level, and you can see that with the little turnaround, of the need to do more research on the solutions to the problem. This guidance to return to the generation of evidence can also occur at the QI level too. For example, a nurse researcher may find that specific practice change doesn't work in a certain setting as the research had reported that it would. And this would inspire the formation of a question for a research study to determine why. So we have multiple routes to get back to original research. And if there isn't enough research, as we said, you can do more research or you can pick another problem because we have plenty in healthcare. So for dissemination, here we've arrived at the top. And the goal of the EBPQI initiative is, of course, to improve health and healthcare. Therefore, dissemination is so critical. That way, other nurses and healthcare professionals facing similar situations can transfer that project knowledge into their own context. So this culminating step is achievable for all nurses throughout healthcare teams. So here you see the mountain model represented in a little bit of a different way. And so to our audience of nurses here, please note that the larger circle represents a leadership role. Now, these are not hard and fast requirements, but we wanted to strip away some of the additional information of the mountain and place specific nursing roles on here. Now, we recognize that DNP, which stands for Doctor of Nursing Practice, which is how Julie and I are prepared, that's not available in all countries that are attending today or that will be listening to this webinar. But specifically, these individuals are trained in evidence-based practice and also quality improvement methods oftentimes. And so just note that as we look at this here. But the point of it is to show that everybody has a spot in evidence-based practice quality improvement. And so at the bottom, at that external research level, the PhD has the larger role because these individuals are prepared in original research. And then you see MSN, DNP, and all other nurses there as well, because everyone has a spot on the team. It takes a team to do these initiatives. They're hard work, and we need the involvement of everybody, including other professions. Then the next level, evidence-based practice, you see everyone there. And although, as I mentioned, DNPs often have expertise in evidence-based practice, or anyone can if they go and get like the new evidence-based practice certification or different kind of training and education, you can get more expertise. But what we have everybody equal there because it's the responsibility of all nurses to ensure evidence-based practice for all patients and to do these projects. And then up at the quality improvement level, you see the DNP in more of a leadership capacity there because of the training, but PhD, MSN, all are there as well. And the MSNs particularly can be helpful in their area of specialty. And then at the top, it's the responsibility of everyone to make sure that the work, the valuable work that's done is shared widely so that we can learn from it. So another aspect of the mountain model that eludes the traditional research process or evidence-based practice process is sustainability, as we talked about before. So the EVP models, they focus on finding and critically appraising and synthesizing that research to develop best practice recommendations to improve a specific problem. And then once this process has been completed, the identified recommendation is combined with that expertise of those who are involved in the preferences of patients and families or other groups to develop that practice or that process change, policy, protocol, or guideline. And then everyone is informed and engaged, comes on board with the expectation that when implementation science principles are used, which is a form of research, that the practice change will occur. And so that's what happens ideally, but then what? Once that practice change has occurred, what happens next? So then the EBP model ends, and there's not a systemic path for continuing monitoring of our intended outcomes. So how will people or the organizations involved determine whether that practice change was effective or if it continues to work? And that's where linking of EBP and QI into one model cohesively helps address this gap. It systemically moves from the generation of research to the application of research and practice, and then combines with the monitoring of this application to help ensure the highest quality of care throughout that evidence continuum. Now, we want to take a moment here near the end, and looks like we're going to have a good amount of time for Q&A, which is great. But there's something called the peak in rule. I don't know if you've heard of it before, but that's where people remember the peak, what they perceive as the peak of an experience, in the end more than its totality. So here in our hour together, you may remember what you think is the best moment with Julie and I and all of us together, and the ending. And so we're putting this at the end strategically, hoping that you will remember it. But a common critique of evidence-based practice QI initiatives is that they're only local, and therefore their results are not generalizable, new knowledge with sufficient rigor to be published in the nursing literature. But what we know to be true is that best nursing practices are always of utmost importance and relevance, and well-done EBPQI initiatives produce that best practice knowledge that's transferable as appropriate to similar populations and settings. So it is useful. And that's why dissemination is so key, because this can shorten that time from research publication to application or practice change. And so we've got to share these initiatives. Ideally, they save money and they allow organizations to choose the interventions with the highest likelihood of success based on what's published. So we really need these in the literature. So conclusions: through a blended approach of EVP and QI with routes to research, the Mountain Model offers a modern approach to practice change that we hope can strengthen practice initiatives, increase the research to practice connection, and target decreased gaps in translation times. For a long time, the evidence to practice gap has been cited to be stubbornly locked at 17 years. And that's always haunted me because that's almost the pediatric lifespan, right? That is a long time. And there's been a lot of really good work done by a lot of hardworking people and pioneers to try to shorten that. But as of, I think, 2021, in cancer care, which is supposed to be our cutting edge, we're at 15 years. And so that will take us a very long time to get these new papers that we know from research that we're relying on our colleagues in research to produce all the way to where it counts, which is with human lives, right? So that's a really long time. So timely use of the Mountain Model, we hope, can also help clarify some of that current confusion and what constitutes research, evidence-based practice, and QI, and how they work synergistically together, right? Because we need all three to be providing quality care. We hope that that is the case. We also hope that nurses can visualize where their educational preparation and or their professional nursing experience really best positions them to lead and participate in research and evidence-based practice and QI teams, because there is a spot for everybody. And so we hope that by seeing the Mountain Model presented in that different way, that will be an encouragement to people. Both the PPCO as a larger umbrella framework and the Mountain Model are in press at the American Journal of Nursing. And so those will be available open access soon for anyone who wants to learn more about them. They're free. But we hope that you'll consider using the PPCO and the Mountain Model, because they're largely untested, in your practice, and let us know how it goes. So at this time, we would love to take any questions or comments or concerns from any of you who would like to share.
This is wonderful. Thank you so much for sharing all of that information. We've had some great engagement in the chat, and we have several questions. So we're just going to kick it off. One participant said, "This is awesome. Wish I had this when I was completing my DMP." And then she says she was thinking about applying your model for a new project. Is this in book form? How do we get the resources? And does your model address research hierarchy? So meta-analysis, expert opinion, etc.
Thank you, Linda. Julie, do you want to take that?
Sure, I can start. The first part of that question, I think, was how can you get these resources? Well, both the PPCO nurse searching question framework is in press, as well as the mountain model, and they both will be coming out in the American Journal of Nursing, and they will be open access. So everyone should be able to have access to these things as soon as they're up online. We do not know exactly when that will be, but you also will have, as I believe our host said at the beginning, access to this recording afterwards. So that can be your reference for now until our work comes out in AJN. And then the second part, I'm sorry, now I'm forgetting.
The hierarchy. So does it?
Oh, absolutely. Yes. The research hierarchy is still the huge component of the critical appraisal of the evidence, which is definitely part of evidence-based practice within the model.
All right. And then coattailing off of that, what about how can we implement these principles when we are looking at magnet program submissions? What does that look like, and how can the model be used in that framework?
Well, I'm not an expert on magnet accreditation, but I do believe that this model is actually a perfect model for a hospital who wants to frame what it does as it goes up for magnet designation, because it includes research. It includes identifying problems that need research, as well as those where there is enough research out there to support practice change. So I believe it is actually probably really great for organizations to think about using as they prepare for magnet application.
And we encourage people to test it, test it with research, because we haven't done that. It's brand new and we want to hear how it goes. And to go back to the original question about, I wish I had it in my DMP project, I do as well. And I really went to Julie asking her, and Julie is a marathon runner and she runs a lot of mountains. So that's part of the inspiration there. But I said, please, we've got to come up with something. And so as that part largely came out of her brain as these paradigms were merged together. But I wish I had it too. And I've been looking for it as I have interim oversight of a DMP program myself, looking for a framework that could be used for our DMP students.
That's wonderful. Thank you so much for sharing all of that. Now, speaking of the model and in the hospital clinical setting, how do we engage bedside nurses in the evidence-based practice process, as opposed to, we know that typically the higher degree nurses or leadership position nurses are heavily involved, but what about the nurses that are providing direct patient care?
I think Jane can probably speak to this, but one of the reasons that we developed this model was so that we, in hopes that we could empower newly licensed nursing students, brand new nurses, with the information that they need to really be a part of a team that makes a difference, that works to improve healthcare. Now, it could trickle up or it could trickle down. It could trickle up from nursing education, or it could trickle down if organizations, for example, decide to use this model, but the registered nurse, the bedside nurse, can I hope see themselves in this model and see themselves as part of a team. But I do also think that it is challenging because there is so much burden put on the bedside nurse. I've also heard that quality improvement is the antidote to burnout, that when you feel like you're actually making a difference, that you have more job satisfaction and you have more delight in your work. And if we can give bedside nurses the tools and the information they need to participate, then that would be a win-win for everybody.
Something else that bedside nurses may find particularly meaningful. I mean, who finds the problems, right? We spent so much time looking at problem identification, and it is that front, the nurse that is there providing care, hands-on patient care. A lot of problem identification comes from those individuals. And so hopefully that can be their buy-in from the beginning when they see the problem that they've identified being targeted and ultimately culminating in a quality improvement that's based on external evidence, that hopefully that could get more involvement from the largest, most trusted workforce in healthcare.
Wonderful. Thank you for those answers as well. I'm just trying to sift through. We have lots of comments and questions coming in. There is one that I want to make sure we get to. 1 second, please. Okay. You had mentioned and I apologize if I pronounce this wrong, the Levine model. The Levine model does include patient and family preferences and clinical expertise. These are fundamental to EBP. This is very clear in her work. Can you explain your interpretation of such?
Sure. So with that comment, in the lean model, the 2010 model, on the actual diagram itself, there isn't patient and family preferences nor clinical expertise that I saw when I reviewed it. And so that it's not included on that model itself. And Julie, I'm not sure if that.
Yeah, and just generally speaking, that model was really a great start.
Yes.
I mean, it was it was what really got us going. And it is just not as comprehensive as what we have, although maybe some of the principles are definitely still there.
Yes, wonderful. Thank you. Now, going back to your presentation, we do have a question related to your OB example that you used throughout your presentation. Would the expertise or researcher have to find out why the county department stopped providing home care initially? What do you think about that?
Absolutely.
Oh, go ahead, Julie.
Yeah, there wouldn't be anything wrong with finding that out. This isn't a real, this is one we made up. And I guess I made the assumption that when the OB providers came to town and opened up a practice, then the county felt like that need was being met and they no longer needed to provide it. That is something that's happened in my experience, although not specifically related to this example. And so it's somewhat common when health departments usually try to meet the needs that are not being met elsewhere.
Okay, so we have just a few more minutes. Do you have any closing words, either of you, that you would like to share with the audience, or any last little tidbits of knowledge you want to share?
Well, we thank you all for your attendance and your participation today. And again, we encourage you to use this model. We hope that it's tested, and we'd love to know what your thoughts and experiences are with it. And we thank you for your time.
Absolutely.
So just as a reminder to everyone, we are getting several questions about the slides and the recording. In a few business days, you will receive an email with the link to the recording, which also has the PDF of the slides. So you are welcome to access that via the Sigma repository. If you are not familiar, the Sigma repository is an open access site, so anyone can access it. You do not have to be a Sigma member. We want to thank our speakers today for sharing their expertise with us, and we definitely look forward to hearing more from you in the future. We hope that you've enjoyed this webinar. Please feel free to access sigmanursing.org for any other webinars and information to support you and your colleagues. We thank you so much for attending, and we look forward to hearing more from you soon. Have a good day.